Bismillah ar-Rahman ar-Rahim. I am Professor Hisham Sharafuddin, Professor of Vascular and Endovascular Surgery, Mansoura University. Welcome, our dearest students. Now, I will discuss a very important subject in vascular surgery, not from surgical point of view, also from medical point of view. This subject is venous thromboembolism, which includes deep vein thrombosis and pulmonary embolism. To discuss this subject or to cover the aspects, we must discussing the etiology and risk factors of VTE, symptoms of DVT and pulmonary embolism, evaluation of the patient and the pre-tested probability, diagnostic modalities needed to reach the diagnosis, treatment and the prevention overview, the approved therapy for this disease, length of the treatment, and last is unusual sites of DVT. Before we discuss these points, we must answer these questions. What is the DVT? Why are we discussing VTE and its prevalence? When we predict the occurrence of the disease, how I can reach the diagnosis and the differential diagnosis, how I can investigate, what are the most common complications, or how I can prevent or prophylact the patient, and how I can treat this disease. VTE is a disorder that changing the blood character from the fluid to the solid. What's meant by thrombus formation? This thrombus formed in the deep venous system. Usually it begins on the leg, thigh, pelvis, and may extend to the IVC, and when it migrates, it affecting the pulmonary arteries and leading to pulmonary embolism. The pulmonary embolism occurs when the clot breaks or migrates from the deep system to the pulmonary arteries, and if it affecting the main pulmonary artery, it may be lethal for the patient and bearing a high mortality rate. Why are we discussing DVT or VTE? Because its prevalence is very high. It affecting one person per 1,000 person, or 400,000 per year. It is a very high incidence of the occurrence of the DVT. The incidence increasing with the age. The 30-day mortality is about 30%, usually from the pulmonary embolism. The subsequent the outcome of this disease affecting the vein, it leads to what's called the post-phlebitic syndrome. It affecting more than 30% of the patient within 10 years. Pulmonary embolism, also the fourth leading cause of death all over the diseases. It is the third cardiovascular cause of death after myocardial infarction and the cardiovascular accidents. When I predict the presence of deep vein thrombosis, or what is the risk factors that leading to the presence of this thrombus in the deep venous system? The majority of DVT or VTE occur in non-surgical patients. What is meant by non-surgical patient? Patient in the hospital or nursing at home with malignancy or central venous cluster or superficial venous thrombosis or neurological affection with affection of the lower limb by paresis and so on. Patient with irritable bowel disease due to repeated vomiting and diarrhea, leading to dehydration and the increased viscosity of the blood. Patient with nephrotic syndrome, usually affecting the renal vein, which is involved in 35% of the cases with nephrotic syndrome, because of the urinary excretion of antithrombin 3 and the related hyperactivity and the increased the elevated plasma viscosity, all of these leading to presence of DVT or renal vein thrombosis. Another factor is the traveling, especially long distance traveling for more than 10 hours using the cars or trains or airplanes, because of the immobility of the persons, and it leads to hypercoagulability and presence of deep vein thrombosis. Another very important factor is malignancy. The incidence increase with the presence of pregnancy. You can imagine that after resection, you get reaching about 40% of the patients. So those patients are classified as high risk for development of deep vein thrombosis and pulmonary embolism. The most common tumors leading to VTE or venous thromboembolism is the GIT tumors like pancreatic tumor, colonic cancer. Also for ovarian or prostatic tumor, lung cancer, also it is thrombogenic. And when you see migratory thrombophlebitis, you must searching for the malignancy because of the hypercoagulable state. The risk factor in hospitalized patient, usually there is more than risk factors in patient inside the hospital, like class 3 and 4 heart failure, COPD patient, sepsis, advanced age, history of prior DVT, cancer, stroke, and so on, and immobility and bed rest. In surgical patient, some surgery bears a high incidence of DVT, like orthopedic surgery, especially surgery in the joint, hip or knee, or inside the pelvis, like hip fracture, trauma to the pelvis, trauma to the spine, because of the presence of the major veins of the lower limb in this area. Also, operation for cancer. Because of the cancer, as I mentioned, it is a case of hypercoagulable state or thrombophilia. The presence of prior history of deep vein thrombosis increase the risk in obesity and advanced age. Another risk factor is estrogen associated during pregnancy. It increasing the risk by 3 to 6 fold, especially with increasing age. The incidence increased in the first trimester of pregnancy, especially during 6 weeks after delivery at puerperium, due to immobility or the presence of prior DVT, high estrogen level, venous stasis, pelvic trauma during delivery, and acquired hypercoagulable state due to elevated fibrinogen and factor VIII, and decreased the natural anticoagulation like protein S and C. It affecting left leg more than the right leg because of the compression of the right common iliac vein by the left common iliac vein by the right common iliac artery. It is present in some people, and it provoked the DVT development. It is called the May-Turner syndrome. Also, estrogen associated risk factors, females taking oral contraceptive pills. Uh, this is common among women taking oral contraceptive pills with greater risk of development of deviant thrombosis. Higher also in some cases with deficiency of protein S and C and the presence of mutation of factor V Leiden or prothrombin mutation. Um, the greatest risk is after 6 months to 1 year of the onset of the oral contraceptive pills. And also it is proportional to the dose of estrogen and if we using the oral contraceptive containing progesterone more than the estrogen, the incidence of DVT will be decreased. And also the transdermal preparation of estrogen has less incidence of the development of DVT than the oral contraceptive. How I can diagnose, how I can suspect the presence of deep vein thrombosis. Uh, Usually the patient coming with sudden onset of pain, swelling in one limb, pain usually present in the cuff and its character is crampy or bursting balls with ambulation and this pain preceding the swelling. It may affecting both lower limbs and bilateral presentation usually due to underlying malignancy or hypercoagulable disorder. It enters in the differential diagnosis of the pain in the lower limb, like arterial occlusion, but in the case of the arterial occlusion, there is absent pulsation, neurogenic pain due to nerve compression, and it is positional, not dependency like DVT. Also for osteogenic pain or joint pain and so on. Pain in the lower limb enter the differential diagnosis with the DVT, but the DVT usually with sudden onset with prior risk factors and the presence of swelling of the limb. Also, it enters the differential diagnosis with the swelling of the limb, like cases with lymphedema due to lymphatic obstruction or cases with chronic venous insufficiency. Also, the most common presence of disturbed Becker cyst in case of osteoarthritis or hematoma on the cuff with edema of the limb and pain. It also enters the differential diagnosis with DVT. So we must confirm our diagnosis by investigations, which is very important to reach the diagnosis and taking the therapy as early as possible. A duplex scan can differentiate between all these causes of acute lower limb pain and swelling. The second item of VTE is pulmonary embolism, and usually it comes with vague presentation, but when the patient has history of deep vein thrombosis with abrupt onset of dyspnea and the cough and scopal attack or pleuritic chest pain, we must suspect the presence of pulmonary embolism of the limb and with the edema at the ankle and also color changes due to venous congestion. And when I doing dorsiflexion for the ankle, the patient gets severe pain. It is not pathognomonic for DVT, but it can occur due to any muscle spasm or tendon spasm, like spasm in tendon Achilles. So we can differentiate by using a non-invasive technique like duplex scan to show the obstruction of the venous system. Now we get the evaluation of the risk factors in patient with DVT. To reaching the whose patient taking the prophylaxis to develop deep vein thrombosis, or whose patient in high risk. So the patient in active cancer taking 1 point, paralysis or recent limb casting 1 point, recent immobility more than 3 days 1 point, local vein tenderness 1 point, limb swelling 1 point, unilateral calf swelling more than 3 days 1 point, collateral superficial vein 1 point. So the patient has 3 points. It is high probability and high risk group. From 1 to 2, it is moderate, and if the patient has only 1 point, it is low risk to develop DVT. And each type or each group of patient can be prophylactic with using some prophylactic measures, as I mentioned later on. Also, for pulmonary embolism, the probability is higher when there is clinical symptoms of DVT, taking 3 points. Patient with heart rate more than 100 takes 2 points. Immobilization or surgery within 4 weeks, 2 points. Prior DVT, 2 points. Hemoptysis, malignancy, and so on. The high probability is more than 6 points. The moderate probability from 2 to 6, and low probability of development of pulmonary embolism is less than 2. So this to how to prophylact the patient against DVT and pulmonary embolism. Here you can see the normal vein with normal blood flow and the presence of DVT and the clot adherent to the wall of the vein, and can be detached and migrating to reach the pulmonary vessels and leading to pulmonary embolism. So this is the cross-sectional through the vein showing the presence of the thrombus, and this is the edema of the right lower limb due to the swelling due to deep vein thrombosis. What is the investigation needed, or how I can investigate the patient suspecting to develop DVT or patient with swollen acute lower limb pain? First of all, the ultrasound or duplex scan, which means Doppler ultrasound plus B-mode scan, it is a very important tool to diagnose, non-invasive tool, has sensitivity more than 85 to 90% and specificity more than 90%, may reaching 100% in highly skilled persons to diagnose DVT. These studies done in the popliteal vein, in the femoral vein, in the iliac veins, and there is some limitation when we assessing the veins, big veins in the pelvis, because of the gases of the colon and also the bone barrier, but we can reaching the diagnose the DVT in the axial veins like external iliac vein, common iliac vein, even in the lower part of the IVC by using duplex scan. Also CT scan, ventilation perfusion scan can diagnose the presence of pulmonary embolism. This is an example of duplex scan showing dilatation and the echogenic thrombus inside the vein. It is beside the artery. This is a common femoral vein. Also, for the longitudinal section, we can see the presence of dilated veins, non-compressible, and here in the lower part of these photos, the presence of partially occluded vein with blood flow and thrombus not completely occluding the lumen. This is example of the CT scan showing occlusion of the pulmonary arteries with saddle thrombus as the above picture and the lower picture, and the left-sided picture in the pelvis, CT of the pelvis showing the dilatation of the with loading thrombus on the common iliac and external iliac vein. And when we're doing venogram, in some cases with distal DVT, we can diagnose the presence of the abruption of the dye due to the presence of the thrombus in the common femoral vein and also in the popliteal vein, as above picture showing the filling defect by injecting the dye inside the vein. For pulmonary embolism, the pulmonary angiogram is the gold standard, and it shows the presence of the clot inside the pulmonary artery. The dimer test, it is a sorbent degradation fibrin product. It is a good negative, not good positive, because it can increase in the presence of trauma, surgery, pregnancy, abdominal aortic aneurysm, and other pathology. But its importance in the follow-up of the patient, especially patient taking fibrinolytic agent as a treatment, when the increasing of the D-dimer and then decreasing after treatment, it means the improvement of the patient. And in the follow-up of the patient also, it is very important to scan the patient who suspecting to develop DVT when there is increase of the D-dimer. So it is a very important test for the diagnosis and for the follow-up of the patient. What is the most common complication? There is some serious complication or acute complication of DVT, and also for the late complication or chronic complication of DVT. For the acute complication, so far, the pulmonary embolism is the most important complication of DVT because it is an emergency and the patient must be hospitalized and admitted to the ICU to guard against more progression of the occlusion of the pulmonary arteries and the arteries and the decrease in the ventilation perfusion, and the patient may need ventilation if the main pulmonary artery is occluded. So it is very important to admit the patient or hospitalize the patient and begin on the start anticoagulation as we see in the management of pulmonary embolism. So the most important complication as acute complication is pulmonary embolism with the grades of this pulmonary embolism from mild to moderate to severe or massive pulmonary embolism. The second complication is a venous gangrene. Venous gangrene is a very challenging complication of DVT due to obstruction of the superficial and the deep venous system, which including all venous return of the limb and leading to venous gangrene that bears a very high incidence of morbidity and even mortality for this patient. For the late complication or chronic complication, recurrent DVT, varicose vein, chronic venous insufficiency, or post-phlebitic syndrome, which presented by pain, edema, and color changes. And the most nauseous complication is the ulceration due to obstruction, or high regurg after recanalization of the deep venous system. So this is a picture of venous gangrene extending from the foot to the below the knee, and this patient ended by above knee amputation. And another example of venous gangrene and phlegmasia cerebellans due to obstruction of the venous system of the limb, venous drainage all occluded. Uh, how the DVT ended by post-phlebitic syndrome or post-thrombotic syndrome or PTS. As we see in the left side of the picture, it is a normal venous flow with intact valve. When recanalization occurred, the destruction of the valve occurred also, and the flow become bidirectional flow from distal to proximal and from proximal to distal. This turbulence of flow leading to venous congestion and the edema of the limb, and also the presence of the residual thrombosis makes the venous return slowly and increasing more congestion, more edema, and more color changes and development of the post-thrombotic syndrome. This post-thrombotic syndrome, as we see, presented with edema, with color changes with dilated veins on the lower limb, also with veins crossing the inguinal ligament. It is very important sign of the post-thrombotic syndrome if there is still proximal obstruction, or the DVT already is present in the iliofemoral segment. We can see the veins crossing the inguinal ligament up to the lower abdomen. Also, color changes due to healed ulcers or hemosiderin deposition, subcutaneous tissue, and ended by ulceration of the leg, which is called post-phlebitic or post-thrombotic ulcer, that needs treatment, and it is impairing the quality of life of the patient, especially when affecting young males, who impeding the patient to restrict his work, to stay in the home, and to using compression stocking all the day and the night. So it is a very nauseous complication for the patient and for the quality of the life of the patient. Uh, in this part, we will discuss how I can prevent, how I can prophylact the patient, and also of the patient already coming with DVT, how I can treat it. Prevention is our primary goal, to guard against the complication, either the acute complication, as I mentioned, the pulmonary embolism and venous gangrene, or chronic complication like post-phlebitic or post-thrombotic syndrome. The prophylaxis, we have many steps of prophylaxis according to the risk factor of the patient, according to the probability of the development of the DVT. So we begin with the enhancing the movement of the patient not stay in bed after surgery, patient usually moving to move the blood inside the veins and enhancing the venous return, and the preventing stagnation, which leading to increase the viscosity of the blood and thrombosis. So we, in mild cases, we're enhancing the movement of the patient. Mild to moderate cases, we can using also elastic stocking to do massage or compression of the veins of the leg, and prevent stagnation of the blood and also to enhance the venous return. But in moderate to high risk patients, we must induce the pharmacological treatment by low dose of unfractionated heparin or low molecular weight heparin. And if the patient is high risk, we can extend the treatment by doing bridging with oral anticoagulation like warfarin. If the patient not responding to unfractionated heparin or low molecular weight heparin, we can use the ultra molecular ultra low molecular weight heparin like fondaparinux as a prophylaxis. And if the patient is high risk for development of pulmonary embolism, as patient with recurrent DVT, as patient with contraindication of anticoagulation, as patient not responding to anticoagulation, we can inserting IVC filter to prevent the propagation of the thrombus to the pulmonary arteries. So we have many types of prophylaxis to the risk of the patient. The post-phlebitic syndrome, as I mentioned, is one of the most common complications of DVT, and it is impairing the quality of the life of the patient. And it also degrades according to the site of the obstruction, the extent of the obstruction, and the presence or absence of venous obstruction plus or minus venous regurg. So the most valuable methods of treatment of post-phlebitic syndrome is the compression stocking. The compression stocking may be in the leg or extending also on the thigh with class 2 compression, making the compression about 30 or 40 millimeter mercury against the vein. And when we're applying this stocking, we must evacuate the venous drainage by elevation of the limb. Then the patient wear the elastic stocking after evacuation of the veins and the massage of the cuff to evacuate the veins and enhancing venous return. Then he wearing the elastic stocking will be beneficial for this patient. The pharmacological treatment using heparin, and heparin is the most popular treatment of DVT. It prevents the complication and the propagation of the thrombus. It prevents the recurrence of the thrombus, and it decreases the pain due to unknown etiology, but it decreases the pain developed by venous obstruction. It is a pentasaccharide with different chains and facilitate and catalyzes the antithrombin 3 mediated thrombin inhibition. So it depends on the presence of the antithrombin 3 as one of the plasminogen activator. And can be monitored by activated partial thromboplastin to be double or triple the normal. And when we administrate the unfractionated heparin, we doing overlap with oral anticoagulation like vitamin K antagonist after 5 days, and we can begin from day one to do this bridging because of the late onset of action of the oral anticoagulation or vitamin K antagonist about 5 to 7 days. So we must do this overlap to reaching the INR, international normalizing ratio, to be 2 to 3 folds of the normal after 72 hours or after 4 days, maybe more, according to the patient hemodynamics. There is some resistance to heparin in about 20% of the patient who require high dose of unfractionated heparin and may be not affected also. And we can shifting to another anticoagulation if there is no increase of the activated partial thromboplastin. And the most nauseous complication of heparin is heparin-induced thrombocytopenia, what's called HIT. Due to can be diagnosed when there is 50% drop in the platelet or platelet less than 100,000 platelet count, affecting about 5 to 7% of our patients. And after 5 to 10 days of administration of heparin, and can be also after disconnection of the heparin and after third day of treatment with heparinization or discontinuation. And this is very important to monitor the patient taking unfractionated or low molecular weight heparin by regular assessment of platelet count to guard against platelet-induced thrombocytopenia, especially when the patient develop petechial hemorrhage or resistance of the thrombus recanalization. So this is a diagram showing how the anticoagulation works, even if parenteral like heparin or low molecular weight heparin, or oral anticoagulation like vitamin K antagonist or new oral anticoagulant or direct oral anticoagulation. You can see here that the unfractionated heparin working in all factors and also for the platelet. The low molecular weight heparin is more specific. It works on the activated factor 10. The oral anticoagulation like vitamin K antagonist working on the coagulation factor depending on vitamin K, like prothrombin, activated factor 7, activated factor 9, activated factor 10, activated factor 2. So all these factors depending on vitamin K, so it is called vitamin K antagonist, which is the most common is warfarin group or coumadin group. Then the new oral anticoagulant, which is more specific and acting either to inhibit activated factor 1 in the intrinsic pathway like apixaban, indoxaban, rivaroxaban, or inhibiting the activated factor 2 like dabigatran. So it is more specific and less complication and good compliance with the patient because it's taken with oral and it not associated with some limitation of vitamin K antagonist like food or factors affecting the vitamin K that antagonize action of the vitamin K antagonist like warfarin or coumadin. So new oral anticoagulant or direct oral anticoagulant is more specific and effective in the treatment of DVT and as maintenance therapy after discontinuous disconnection of the injectable heparin or low molecular weight heparin. This is the warfarin, as I mentioned, it acting on the factors depending on vitamin K, like factor 2, factor 7, factor 9, factor 10. Uh, the low molecular weight heparin, it is a small fractionated heparin. Its molecular weight ranging from 40 to 60 Dalton. It is more specific and high affinity to activated factor 1, factor 10. Can be safely taken twice daily or once daily according to the half-life of the low molecular weight heparin, and can taken subcutaneously as home therapy with less complication like bleeding. So it is one of the most effective therapy for DVT and even prophylaxis, as I mentioned. The presence of heparin-induced thrombocytopenia is less than the unfractionated heparin. It reaches about 1% of the cases, and they can be monitored by uh, measurement of the activated factor 10 level in the blood. We don't use it usually, but if there is any indication like the patient not responding or the patient with complications, bleeding, we can measure the anti-factor 10 level in the blood. Fondaparinux is one of the ultra-low molecular weight heparin. It is synthetic pentasaccharide and is more specific and given subcutaneously and excreted also by the kidney and can be used instead of low molecular weight heparin and unfractionated heparin in case of the resistance of the hit. So it is safe, but the bleeding tendency is more than the low molecular weight heparin, and it occurs more than the molecular weight heparin about 2 to 3% of the cases compared to 0.2 to 2 in case of low molecular weight heparin. Also can be measured by assessed by measuring the activated factor 10 in the blood, like the low molecular weight heparin. This is the oral anticoagulant available in the market, the warfarin or coumadin, dabigatran or paradoxa, rivaroxaban or xalert or apixaban, like liquids. And as I mentioned, the action of these drugs is more specific either on the activated factor 10 or activated factor 2. This is the most available direct oral anticoagulant present in the market, rivaroxaban and apixaban, acting on activated factor factor 10, like also low molecular weight heparin and fondaparinux, or dabigatran, which acted on the activated factor 2 or prothrombin. The inferior vena cava filters. These filters are not for treatment of DVT, but it prophylactic against the propagation of the thrombus to the pulmonary arteries. Indications of these filters, we must follow the guidelines of this filter indication. The most important of that is the contraindication for oral coagulation, like patient with bleeding tendency or patient doing major uh, surgery in the brain, or patient in the ICU with bleeding, or patient taking anticoagulation, but instead he developed the recurrent DVT or pulmonary embolism. For all of these patients, we can use IVC filter and insert it below the renal veins, either through the femoral axis or through the internal jugular axis. Prevent the pulmonary embolism, and we have two types: the permanent one, which is condemned now, and the retrievable one, which can be retrieved during the first 3 weeks or 1 month after insertion. And the presence of these filters can protect the patient against the development of the pulmonary embolism. But we have some complications that leading to strict its use to the guidelines, as I mentioned before. We have the risk of migration, the risk of fracture, the risk of thrombogenicity of the filter itself. So we use it as temporary IVC filter if we need to use it due to the bleeding tendency or recurrent thrombus instead of the anticoagulation, or patient doing major operation. Also, for the treatment, there is the lytic therapy or fibrinolytic therapy. This lytic therapy can be used in the proximal DVT and also on pulmonary embolism. It's used also is restricted for proximal DVT like iliofemoral DVT or phlegmasia, steroidolens or phlegmasia albadolens, or patient coming with recent pulmonary embolism or massive pulmonary embolism can use catheter-directed lytic therapy. This lytic therapy, the most important of this lytic therapy is streptokinase, but the streptokinase has some complication like antigenicity, and they may leading to anaphylactic shock in some patients. So we restrict its use after loading a small dose, and then if the patient can't relate without anaphylaxis, we can continue the treatment. But it is now its use is restricted because it is non-specific and it can lead to major bleeding. But it is cheap and available. Urokinase is more specific and less bleeding tendency, and can be used also. And nowadays, the TPA or tissue plasminogen activators, which is safe and specific with less bleeding tendency, but the cost is the only restriction for its use. So there is alteplase, eritaplase, tenecteplase. This is the TPAs which used in management of acute DVT and pulmonary embolism. The use of this lytic therapy can be used as systemic anticoagulation, but it is restricted in acute coronary syndrome or cerebral stroke, thrombotic. But in venous thromboembolism, we're preferring to use it as a local use, which is called caster directed thrombolytic therapy. By inserting the caster through the femoral vein and passing this caster through the thrombus, then injecting the thrombolytic material inside the thrombus to get the benefit of the drug and to prevent its complication like major bleeding. So nowadays, castor diuretic therapy is the one of the tools to treat the proximal or iliofemoral DVT or patient coming with seriodolens or phlegmasia alba-dolens. It is one of the most reliable tools to manage this presentation, the proximal DVT. Also, there is may be used as caster directed lytic therapy only or combined with mechanical pharmacological lytic therapy like trails and also with ultrasound like echoes. It is a new modality for treatment, local treatment of the proximal DVT and the pulmonary embolism. For the pulmonary embolism, they may be used as intravenous thrombolytics. The dose is 100 milligram over 2 hours of TPA, or caster directed lytic therapy for infusion or mechanical thrombolysis or mechanical pharmacological thrombolysis or surgical embolectomy. The length of treatment of DVT, we have guidelines for how I extend my treatment for patient coming with DVT. For provoked or identified etiology, like patient after surgery or hospitalized patient, we extend our treatment for 3 months after the beginning of the therapy by oral anticoagulation, either vitamin K antagonist or new oral anticoagulation, new oral or direct oral anticoagulant. We extend our therapy to 3 months, guided by duplex scan. For idiopathic or non-provoked DVT, the recommendation is 6 months treatment, may extend to 1 year to prevent the recurrence of DVT. But in patient with malignancy or patient with thrombophilia, we can extend our treatment for lifelong treatment because of the presence of the deficiency of plasminogen system or increase of the coagulation factors, which needs to be anticoagulated lifelong. This is the group of patients that called patient with hypercoagulable states. The complication of treatment by vitamin K antagonists, as I mentioned, skin necrosis due to presence of the thrombosis in the capillary and the venules result in the dermal necrosis, and it is one of the most noxious complication of VKA antagonist. Now we're reaching the last part of this lecture, is the unusual site of the DVT. Upper extremity thrombosis it is usually present due to thoracic outlet syndrome and compression of the subclavian vein, or the presence of malignancy like cancer breast, or in congenital or acquired thrombophilia. The incidence of pulmonary embolism is less than the lower limb DVT, and the post-lipidic syndrome also is less than the lower limb DVT because of the presence of the collateral venous limb. The diagnosis is also by duplex scan or CT or MR, and the treatment is the treatment of the cause, like decompression in case of thoracic outlet syndrome, venous decompression of the vein, or removal of the central case when there is insertion of the central case in the subclavian vein, and then anticoagulate the patient till 3 to 6 months. The mesenteric venous occlusion, it is one of the most common causes of acute abdominal pain when there is history of DVT or history of VTE in this patient, and you must searching for the cause, maybe GIT malignancy, underlying liver disease, pancreatitis, and this is the one of the causes of portal hypertension. So the patient may coming with signs of the portal hypertension that like variceal bleeding or ascites, or acute abdomen with bowel infarction, jaundice, vomiting, weight loss, and the diagnosis by duplex scan and CT and MRI. The treatment, anticoagulation or lytic therapy, and exploration if the patient not responding, and dealing with the bowel. If the bowel is not viable, we resect and do an anastomosis, and it may be combined with thrombectomy or insertion of a caster directed lytic therapy for the mesenteric vein. Second is the renal vein thrombosis, which is associated with nephrotic syndrome, and the incidence is about 1.9 to 40% of cases of nephrotic syndrome. The etiology is idiopathic or due to malignancy, renal cell carcinoma. The presentation also is asymptomatic, or maybe patient coming with renal failure. And the diagnosis by duplex ultrasound or CT or MRI. Therapy conserve renal parenchyma, anticoagulation. Also, we can using lytic therapy in the renal vein, and in nephrectomy. We must we must preserve the kidney as we can, except if there is renal failure, sepsis, we can do nephrectomy. Ovarian vein thrombosis, it is a rare complication, may occur in the right side more than left side, and may associated with suppurative pelvic thrombophlebitis. And the presentation, if there is associated with inflammation, the patient coming with unexplained fever, I may complicating by primary embolism or extension to the IVC, may leading to ureter obstruction or recurrent thromboembolism. The diagnosis by clinical due to pelvic pain or postpartum pain due to, when associated with sepsis. CT and MR is valuable, and ultrasound also. Therapy with anticoagulation and antibiotic if associated with inflammation or ligation of the ovarian vein when we diagnose as ovarian vein thrombosis. Budd-Chiari syndrome, it is rare condition due to occlusion of the hepatic drainage by tumor like hepatocellular carcinoma, renal cell carcinoma, Wilms tumor. maybe congenital obstruction, myeloproliferative disorder, and we have different types of Budd-Chiari syndrome. Type 1 IVC is occluded, plus or minus hepatovenous obstruction. Type 2 occlusion of the major hepatic vein. Type 3 fiber subluxation of the centrotubular intrahepatic venules. And this is not diagnosed except postpartum. The symptoms, the patient coming with venous hypertension, hypoxia, hepatocyte necrosis, hemorrhage, diagnosed by Doppler ultrasound or Doppler scan, MR, and CT, and the treatment, the anticoagulant therapy, the lytic therapy, or we can using a surgical shunt like TIPS and insertion of stents in the hepatic veins. The last subject is a cerebral venous sinus thrombosis and affecting young to middle-aged woman. There is no different, no specific etiology except in cases of hypercoagulable state and maybe idiopathic hormonal therapy, malignancy, venous malformation, postoperative dehydration, and so on. The patient coming with headache, focal neurological deficit, seizures, alternation of the conscious level, and the diagnosis by CT, 80% of cases, and MRI is more sensitive. Cerebral angiogram, it is especially venogram, it is for definitive diagnosis. The management usually by anticoagulation, either unfractionated or low molecular dose heparin for oral anticoagulation. The retinal vein thrombosis, usually retinal vein thrombosis associated with retinal arterial atherosclerosis in patients with hypertension, diabetes, cardiac disease. So the patient coming with retinal artery atherosclerosis and may also with retinal vein compression and stasis. The patient coming with blurring of vision, macular edema, maybe coming with vitreous hemorrhage or glaucoma, and this with anticoagulation, it is questionable. Topical steroids, cryotherapy, photocoagulation, or maybe surgical decompression in some cases. So this is the last subject of my talk for the vena thromboembolism is the unusual sites of vena thromboembolism. I hope this subject is covered in all aspects, and if there is any question, you can contact me in vascular surgery department in the second floor in the main university hospital. Thank you very much. I hope you understand this subject and you get benefit from knowing the etiology, classification, diagnosis, and the treatment of VTE. Thank you very much and goodbye.